Mabuhay, magandang hapon sa inyo lahat. I'm Dr. Bong Buenaventura. Share my screen. I'd like to thank the Department of Medical Humanities, particularly Dr. Cristina Cruz, for the opportunity to talk to you today about this very important topic. According to the WHO, these are the number of people who die per year, per day, per hour, per minute, and per second. But of course, this information was pre-pandemic, and we would be expecting that during the pandemic, the numbers have gone higher. In fact, in the United States, deaths due to COVID have ranked #1 as far as causes of death. Thanatos was the winged god of death who wielded a big sword, and therefore the study of death and dying was named after him, thanatology. Before we proceed, let me operationalize some terms so that we are on the same page. Grief is the emotional reaction to the loss of a loved one. Mourning is the process of resolving that grief, and bereavement is the state of being in grief. These words are often used interchangeably, but they are not technically interchangeable. So please take note of the differences. I like to start my clinical lectures with a case vignette. And this is based on the true story of a real patient. The details have been changed to protect her identity. Aling Ophelia is an elderly female married to a recently retired businessman and the mother of a young physician. She had just been diagnosed to have cervical cancer and was referred to psychiatrists because her medical oncologist noted her to be very worried. Upon assessment, it was determined that a month prior to her diagnosis, the patient's mother had died suddenly of a heart attack. This occurred while the patient and her husband was in the middle of their second honeymoon abroad. Being the eldest child, she took it upon herself to manage the wake and burial and thus had to cut short her vacation with her husband. With no prior history of mental illness, the patient was noted to have depressed mood and appropriate affect. There were no perceptual disturbances and her responses were coherent and goal-directed. However, there were significant guilt feelings and self-blame, but no suicidal ideations. He manifested poor sleep, poor appetite, loss of interest and pleasure in usual activities, poor concentration, and weakness. He was diagnosed to have major depression. We will talk a little bit more about the patient later. My main objective for this lecture is to discuss pertinent issues relevant to the dying process, including the 5 stages of emotional responses and ways to deal with a terminally ill patient. Following are the specific behavioral objectives. So let's define a couple more terms. Now, death is the inescapable end of life that will touch everyone at a specific point in time, while dying is the process that ends in death. These have always been complex and controversial issues. As a point of information, there are a lot of issues related to this topic that we will not be able to discuss in more detail due to time constraints, but I will leave it up to you to look this up if you're interested. Essentially, there are 2 social concepts pertaining to death and dying. The first one would be the traditional social concepts, and the second one, of course, would be the modern social concepts. Let's talk first about the traditional social concepts. In the traditional social concept, death and dying are seen to be a normal part of life, and that the goal would be to provide comfort, and that the patient or the individual usually dies at home. And death is always seen as a welcome relief. And that after death, individuals believe that there would be reincarnation to usually a better form of life. And that's why we often see this kind of social concept in Eastern cultures. Now, how about modern social concepts? In this social concept, death is seen as a failure of medicine. And that's why the goal is often to find cure for the dying patient. And as a result, a lot of them die in institutions. And as a result also, individuals in the modern social concept want to postpone their dying if possible. and life is seen as finite, and therefore, as a result, we see this more commonly in Western cultures. Interpersonal dynamics of the dying process are critical knowledge, and one theory that has received wide acceptance are the 5 emotional stages of death and dying, presented by Dr. Elizabeth Kubler-Ross in 1969. A person's response to one's own dying, however, is far too complex to fit neatly into a model of a linear stepwise progression involving 5 single emotions from denial to acceptance. Thus, remember individual differences in these responses. Not all individuals will manifest all stages or even in the same fixed sequence. We need to remember also that sociocultural factors play an important role. Dr. Kubler-Ross was a Swiss psychiatrist who pioneered near-death studies and who, as part of her residency training in the US, promoted and encouraged a more humane approach to the dying patient. She was very disappointed to see how the dying patients were treated, including being shunted to one corner of the ward and hidden from view by curtains. She started to write articles and give speeches, what would be equivalent now to what we call blogs or vlogs. Her approaches were crystallized in a best-selling book that has forged a better treatment of the dying patient and a better understanding of the process of death. So these are the quote-unquote stages of death and dying. They are not literal stages because you don't need to start at 1, then proceed to 2, etc. As I mentioned earlier, these are not fixed stages, and how individuals go through each stage may vary differently. So let's discuss each one. Denial is used by almost all patients in some form. It is usually a temporary shock or disbelief response of bad news. They will say, oh no, that's not true. And unfortunately, this can prevent the person from seeking appropriate treatment if, of course, they're denying that they are even ill. Isolation arises from people, even family members, avoiding the dying person. People can slip back into the stage when there are new developments or the person feels that they can no longer cope. So they may proceed or move forward from denial, but later on come back to it if there are some changes in terms of the status of their illness. The second stage is anger, usually anger at God or a supreme being. So the question that arises, why me? Feeling that others are more deserving. There's also envy of others. Other people don't seem to care and they are enjoying life while the dying person experiences pain and others are dying. Usually the anger is projected onto the environment, and therefore we often see patients become angry towards doctors, nurses, and even family members, and to a certain extent, even strangers. And that's why when you become a physician, eventually later on, and you are dealing with a patient who is in the stage of anger, you need to be very careful. Sometimes they can lash out, not just verbally, but also physically. But you should not, of course, take it personally because you need to understand where they are coming from. The third stage is bargaining. It's a brief stage usually, and hard to study because it is often between the patient and his God. Okay, so it's usually something that's very private. So if God didn't respond to anger, maybe good work will work. Okay, being good will work. Okay, so the patient usually says yes, but okay, and then attempts to postpone that if only I could live to see. Okay. So what they usually would say is, if I donate, for example, 50,000 pesos to charity, I hope you will take away this disease, or I promise to be a better person, more charitable, more compassionate if you take away this disease. So that's the sort of bargaining that usually occurs between the patient and his or her God or supreme being. The next stage is depression. Okay. But this is a general term. It does not necessarily imply clinical depression. So it could be equivalent to sadness or even loneliness. And usually with depression, there is some degree of mourning for losses, okay? And particularly, of course, the loss of life. Okay? And this could be reactive depression due to past losses, such as loss of a job, hobbies, or mobility. It could also be preparatory depression because of losses yet to come, okay? Particularly in terms of a dying patient who becomes, let's say, dependent on other family members for help and support. And the final stage is acceptance. Now, this is not technically a happy stage, and it can be usually be void of feelings. Now, it takes a while to reach this stage, and a person who fights until the end may not even reach it. Okay. It consists of basically realizing that death is inevitable. Now, hope is an important aspect of all stages. A person's hope can help them through difficult times. And this stage of acceptance usually will also involve the issue of closure, not just for the dying individual, but also their loved ones. That's why it's often easier for loved ones to be able to reach that stage of closure themselves if the dying patient is able to develop that sense of acceptance. There are a couple more terms we need to differentiate, but I will leave this up to you as an asynchronous task, looking in terms of the difference between grief and depression. There is one salient difference between these two terms, and this one concerns the characteristic of the love object, the loss of which provokes depression in the self. So remember that in both grief and depression, there is the loss of a love object, except that in depression, the lost love object is usually imbued with a sense of what we call ambivalence. Ambivalence technically is a defense mechanism according to Sigmund Freud. And this characteristic that's imbued in the lost love object can precipitate clinical depression, which of course may be different from grief. Now, I need to emphasize, of course, that grief is a biopsychosocial response to a loss. You understand more about biopsychosocial issues or the biopsychosocial theory when you get to psychiatry, I guess. I'm not sure if they still teach the subject in human life cycle, but you also have a better idea about the biopsychosocial aspects of health and disease when you reach psychiatry. Thus, we need to consider the physical or physiological, emotional or cognitive, and environmental or relational aspects of the response. Now, I'd like to revisit the stages of death and dying. Yeah, the Kubler-Ross model of emotional response is using a change transition curve. So this is simply another way to look at how people can respond to a situation that confronts them with issues of death and dying. So you have an individual who's living his life normally with good health, life is stable, and then, of course, then they're diagnosed of a terminal illness, and this creates a significant change. That significant change can include the formation of denial, also shock, which would be stage 1. And in this situation, the patient or the individual will be beset with avoidance, confusion, and fear. This would be followed by anger or the heightening of emotions. So the individual feels frustrated, irritable, anxious, and even hostile. And this can lead eventually to stage 3 or bargaining, in which the individual struggles to find meaning and trying to reach out to others and hoping to be able to tell one's story. This unfortunately may lead to a movement away from increased self-awareness and contact with others, and eventually the patient goes into a stage of depression characterized by meaninglessness, hopelessness, helplessness, and guilt. But of course, with gradual realization of the consequences of death and dying, the individual can also go into a stage of a process of what we call preparatory grief. And this will facilitate the patient's attainment of the stage of acceptance in which their patient will, or the individual will develop increased self-reliance and will lead to exploring options and making new plans and being able to move on. So those are the 5 stages of death and dying, but of course, it didn't seem to have stopped there because now there is what we call a 6th stage of grief. There has been a assumed finality about the 5th stage of acceptance that Dr. Kubler-Ross never intended. Unfortunately, she died before completing what she was working on with her colleague, Dr. David Kessler. So over the years, they came to realize that there's a crucial 6th stage to the healing process, which is finding meaning. Now, isn't some arbitrary or mandatory step, but one that many people intuitively know to take and others will find helpful. In this next stage, they acknowledge that although for most people, grief will lessen in intensity over time, it may never end. But if people allow themselves to move fully into this crucial and profound sixth stage, which is meaning, it will allow them to transform grief into something else, something that can be rich and fulfilling. Through meaning, people can find more than pain. When a loved one dies or when we experience any kind of serious loss, the end of a marriage, for example, the closing of the company where we work, the destruction of our home in a natural disaster, we want more than the hard fact of that loss. We want to find meaning. Because loss can wound and paralyze. It can hang over us for years. But being able to find meaning in the loss empowers us to find the path forward, because meaning helps us make sense of the grief that we are feeling. Now let's look in terms of how death and dying can be viewed across the lifespan. Let's start with the perinatal or infancy period. Some points to consider when an infant dies. Was it accidental? Was it due to illness? Was it a term pregnancy? Was it a wanted pregnancy? We need to remember that the mother who loses a baby can go into postpartum depression, which is a very common clinical condition. Postpartum blues is the normal variant, but postpartum depression is the clinical variant that would require appropriate treatment. We can also look at the child who loses a parent or parents, and that what is important when a child loses a parent or both parents, that the child will require a stable and nurturing substitute. So it could be anyone, could be the grandparents, it could be an older sibling, it could be aunts or uncles, as long as the quote-unquote substitute parent provides a stable or nurturing environment, then the child may be able to grow up, okay, mentally healthy. Now, how about the young child, those who are about 5 or 7 years old? Now, at this point, the child still has no finite concept of death yet, okay? And the perception usually is like sleeping or going away. However, usually at about 7, 8, or 9, they may develop a better understanding of death, and they will respond emotionally similar to adults. In fact, John Bowlby has seen that children at this age who already develop some degree of cognitive functioning may go into their own unique stages of emotional response to death and dying, which would include protest, despair, and detachment. Then there are the teens or young adults. Usually, young adults or teenagers feel a sense of omnipotence or invulnerability. In fact, deaths due to accidents are usually the most common causes of death in the age group between 15 and 24. Suicide ranks second. And the reason why suicide is very common among this age group, one reason, of course, not the only reason, but one reason is that teenagers usually have a romantic sense of death. They have a romantic view of what death is. Okay, so they think like it's all classical music or flowers, just like, for example, like in Romeo and Juliet. And another point to consider when terminal illness is diagnosed at this stage is that this can result in a lot of anger. They may feel that they are being cheated because they're still so young. Why are they being given this kind of a disease? But this can have a positive outcome when they encounter the death, when encountering death, and this can give them a greater appreciation of life. Particularly, for example, if if the death occurs not within the family, but for example outside the family, like with a friend, okay, then once that happens, then you know you in at this stage, you know, in teenager and young adults, the first time they encounter a significant loss through death, let's say because of someone that they know, let's say close relative or the mother of a very good friend, then it can be very confronting and gives them a better sense of what death is all about. Because this time around, someone that they know directly and someone that they may have a very close relationship with. But if it's someone like a stranger, then usually may not have as much an impact. And that's why the first encounter of significant loss through death can be very disturbing. That's why it needs to be worked through with the parents as well. With the subsequent stages, for example, with middle age, significant changes in perception will occur. Now, they will also consider the possible outcomes in relation to death and dying. As you know, for example, like with middle age, okay, we call this the sandwich generation, right? They're taking care of younger children at the same time, an older parent, and that's why dying at this point in their life can be very difficult to accept because of the responsibilities that they have. And usually this is also the time that they are peaking as far as their career is concerned, and therefore the threat of death at this point can really raise a lot of anger as well, similar to with teenagers and young adults. But they also develop some fears. For example, they don't like long, drawn-out death. They don't like a lot of pain or disability. And generally, as I mentioned, there's an increased anxiety over death and dying because of their responsibilities towards their family and their career. And for example, like they may have a bucket list that they may not have even gone through yet. So that can be very frustrating for them. There's a phenomenon we call the disruption of the natural order. And this is when a parent loses a child. Okay? So when a child dies ahead of its parent, we call this the disruption of a natural order. And the likelihood increases in middle age. Okay? So this can be something that's very difficult to accept because the idea is that parents should die ahead of their children so that when a child dies ahead of its parents or his or her parents, and it can be very difficult to accept. Then finally, late adulthood or old age. Usually the elderly would have a more realistic, accepting attitude. Even some of them may even welcome death, particularly the sick and very frail elderly, and those who are in adverse circumstances. So they may think of death as a release. Okay? And usually the older we get, the more losses we encounter, such as the loss of a spouse and even the loss of a child or even a grandchild and other significant people like friends and other relatives. And usually as the older we get, the less afraid we become as far as confronting death and dying is concerned. The next topic will be about death and dying during the time of COVID. And let me play this short video.
I'm doing this because I want people to understand that this virus, this corona, it's not a joke. You know, I've made jokes about it. Everybody makes jokes about it. I think that's how we deal with it. We make light of hard situations. But Monday, our mum got taken to hospital, Q&E. It looked like it was this corona. And me, my dad, my brother and my sister and all their family have to just sit at home while she struggles in hospital on her own. And you can't go near her, you can't cuddle her, you can't take her anything. And you're praying every day that she's going to come out, that she's going to be all right, everything's going to be okay. That was Monday. Now it's Thursday, and she's gone. She's gone. Just like that, she's gone. And we can't grieve, we can't comfort each other, we can't hold each other. Losing someone's hard enough, but not being able to hold your family close when you do is the most gut-wrenching pain I've ever felt in my life. There were so many things that I had left to do and saying that I didn't get to do. I'm just, yes, people have got to start realising the thing ain't playing anymore. This is serious. I know loads of people have died, but it ain't until it's a bit closer to home that you realise how dangerous it is. I love you, Mum.
That was Mr. Stuart Hamlin of the UK sharing in a viral Facebook post what he experienced when his mother died last year in COVID. So let's proceed. At this point, let me cite a couple of cases that I'm seeing in therapy as the direct result of COVID-19. The first case is Carlo, who's a teenage male, the only child of a single woman, a college professor. On New Year's Day, his mom developed high-grade fever, so he brought her to an emergency room where she was diagnosed to have pneumonia. She was hospitalized and subsequently turned out positive for COVID-19. 2 days later, due to persistent respiratory distress, she was intubated, but several hours later, she passed away. More than a day later, Carlo was handed an urn containing his mother's ashes. Carlo was bereft with grief, guilt, and remorse. Due to the deterioration of his condition, his best friend's mother, his pediatrician, referred him to me, a psychiatrist. The second case is Lani, a middle-aged married woman who has worked in a hospital setting for most of her adult life. Her 90-year-old mother, a widow, lived with her, and despite her age, the mother was highly functional with good activities of daily living, such as going to church, marketing, and cooking the family's meals. Unfortunately, when COVID-19 struck this time last year, her mother was one of the first in their town to get infected. Because there was still a lot of uncertainty at the time about the disease, Lani, despite being a healthcare worker, panicked and did not know what to do except bring her mother to the hospital. She was not allowed to stay with her mother no matter how much she pleaded. She told me later on she felt like a crazy woman shouting at the hospital staff. In retrospect, she felt very bad about her actions, but was eternally grateful to them that they understood what she was going through and did not retaliate. She was also grateful that they entertained her calls at all times of the day because her mother did not know how to use a cell phone. A few days later, her mother passed away, and what Lani regretted most was that she did not have a chance to speak again to her mother and tell her how much she loved her. One of the most hurtful things she experienced was being shunned by neighbors, friends, relatives, and colleagues, even though her and her family's swab tests were negative. She said the stigma directed to the COVID patient and their family was overwhelming. This really is a very complex issue and will require a separate discussion. And because of time constraints, I will just ask you to read this article published in the British Medical Journal last week. To proceed, there are various fears that are related to death and dying. These include physical fears, which would involve helplessness, dependence, loss of physical faculties, disability, mutilation, and pain. Social fears, which include separation from family, leaving behind unfinished business, being a financial and emotional burden to others. Then finally, emotional fears, being unprepared for death and what happens after death. There are also a lot of medical issues that need to be considered. For example, the patient's overall health, the presence of pain and disability, the concomitant occurrence. So, for example, dementia, depression, and other mental health concerns. And also an important issue was whether there should be discussion about organ donation. One of the most critical questions that often arises in terms of institutionalization of dying or terminally ill patient? For example, would they think of palliative care, wherein there's possibility of cure subsequently, or would it be hospice care, wherein the goal is just providing comfort for the patient until the patient eventually passes away? Home care could also be considered, as in the patient could be taken care of at home by healthcare workers, and can also provide respite care for relatives who are looking after a terminally ill patient. That means the patient can be temporarily or admitted in the hospital for short term, so to give the caregivers some time to be able to de-stress or do something else. Comfort care, of course, is the usual goal that we would like to provide, particularly because we are, of course, an Oriental country, and we still now follow the more traditional social concepts as far as providing care for the terminally ill patient is concerned. So this will involve looking after their physical comfort, providing for their mental and emotional needs, and looking into spiritual issues. Actually, it is not something that would be considered in, of course, the modern concept in Western countries, but here in Asia, specifically here in the Philippines, this is an important aspect that we need to consider as well. But we need to be able to at least not maybe not specifically help, but at least facilitate um, some practical aspects or tasks that need to be considered, such as financial considerations, funeral arrangements, and then setting up remembrances. I think from the purpose, from the point of view of psychiatrists, is something that we often do assist the family with, assist the patient with, but it might not be something that an internist or a surgeon might even consider. But it depends on how you would approach the treatment or management of a dying patient. There are also legal issues, but this would not be something that we would specifically discuss here. I think this could be discussed in other topics, for example, in ethics or in legal medicine or jurisprudence. So I will leave it to those subjects to have a better discussion about this topic. So what would make an individual less afraid of dying? What would enable them to be able to prepare and face death? Because number one is, for example, if they have already fulfilled their goals or achieved their goals. Okay? If they have a good degree of life satisfaction, if the family is okay, if, for example, their spouse, friends, and other contemporaries are all gone, like if they're the only one of their groups left, then I mean, it's probably okay for them to pass on if they're also spiritually prepared. And of course, as we have mentioned earlier, that there's already a sense of acceptance of the finality of death. A lot of us would, of course, like to die a good death. And for a lot of people, these are the various characteristics that would constitute what a good death would be. That if we die suddenly, it's not long, drawn out, or chronic. That if we die during sleep, so that when you wake up in the morning, you're already dead. We die at home. When you feel comfortable and life has been meaningful, and even death, even our death is meaningful, that we have had a completed life, or at least a life in which we have accomplished a lot, maybe, or at least some things of significance for ourselves and even other people. When we have done our goodbyes, and I think this is one of the things that are lacking, especially when an individual dies as a result of COVID in the hospital, the inability to be able to at least share some last words with their loved ones. And the next one is, if a life review has been accomplished, it would be good to be able to look back into our life and then see in terms of what we have done. And the last one, of course, if we're surrounded by our loved ones. I think this would really be very helpful if that can be done. When my father passed on a few years ago, this was something, because he preferred to die at home rather than in the hospital. So we got him, even though he was not really that well. Okay. And then he wanted us to be able to be around. So, which we were able to, at least for most of us, and so that we were able to at least say our goodbyes as well. One of the biggest attitudes is that close family members are often too embarrassed to solicit their elders' views on these matters or feel it is harsh, cold, inappropriate, and so forth. So younger members of the family usually don't want to talk about dying. Okay? So it's often overlooked. And that's why when eventually the individual is dying, it may be too late to be able to discuss, for example, what their wishes are. For example, do they want to be resuscitated? Do they want um, a lot of extraordinary measures to be able to sustain their life? So a lot of those things usually are not discussed. So that's truly unfortunate. Now, what are some of the reasons why the dying individual won't talk about it? Well, there are a lot. Okay, these are just some. We won't go through them. For example, like well, one is of course they don't want to be a burden to their family and friends. Not just a burden financially, but oftentimes not also a burden emotionally. So so they gloss over it. They don't want to talk about it. They don't want to discuss it. Oftentimes, for example, like if they're still in the hospital, they don't want to talk about it, particularly if they're in the ward, because of the lack of privacy, and they feel that this is something that's very private between the patient and their loved ones. Okay? And one reason also is that, for example, they could still be in denial about their illness, and so therefore, of course, that would be one reason why they would refuse to talk about it. And oftentimes they're also afraid or anxious about upsetting relatives. Um, because unfortunately, sometimes you have relatives who are really very hysterical, so that the drop of the hat, they would cry intensely, and oftentimes it can be bothersome to the dying patient. So that's why they'd rather not talk about it, so as not to provoke others into um, going into hysterical fits of tears. Okay. And of course, it would usually a dying person, of course, would want to be able to talk about it to someone that they actually trust, that is someone that they're actually uh, close with, and so that if they don't feel that it's something that they share with the individuals who are around them, then of course that may inhibit them from talking about it. And then let's look at the point of view of the loved ones or the relatives. So why won't they talk about it as well? A lot of individuals, because we're afraid to say the wrong thing and may even make matters worse. The term about treading or walking on eggshells, like, so it's oftentimes it seems to be like that when you're talking with a dying individual, because you don't want to insult them, you don't want to make them feel bad. So my suggestion there is to take the cue from the patient or the individual, okay, and then proceed from there. A lot of people also, the loved ones, of course, are also afraid. They're because they're losing someone, and they're also beset with fears and anxieties, and that's why they oftentimes collude with other members of the family as to just like sort of like ignore it, okay? And like what stated you, like pretend everything is all right. Sometimes the patient or the dying individual will play along simply because the patient doesn't want to overburden the family members, but may not be helpful in some instances. But again, it would depend on how the families uh, feel towards each other. There's also some degree of guilt and shame about what had happened in the past. So, for example, especially if they had a difficult relationship early on, then now, dealing with a dying patient that you've been very angry with for most of your life can be troubling. And then, of course, the family members can also be in denial. So they themselves are unable to face the truth about what's happening. So that would be one reason why they don't talk about it. A lot of healthcare providers, including doctors and nurses, are not properly trained in dealing with death and dying, which is very unfortunate, to the detriment of the patient's well-being. For example, like in your case, as first-year medical students, this is probably the only formal lecture that you're ever going to have in your entire 4 years in medical school here. And so, there might not be another opportunity until later on. So that usually a uh, lot of individuals who become doctors are really unprepared as to how to deal with this, and therefore they can be unprepared when the time comes. So I hope they make the most of what we're talking about here, and that you yourself will take the opportunity to read up more about these issues. So what would be your role in the future as a health caregiver? And, of course, when death is the end, and oftentimes you know that it's going to happen for the patient, and oftentimes, in the modern concept now, about we doctors still try to do everything that they can to prolong life, but up to what cost for the patient and for the family. So remember to be able to support and listen therapeutically and make the person as physically comfortable as possible. You can also use your knowledge and expertise to strengthen, support, and prepare the family. Okay. Always consider the possibility that you can refer the patient and or the family for grief counseling, and that's the reason why we have psychiatrists and psychologists. Okay, so if you see that they are in distress, do not ignore that. Okay, step in and offer help in that regard. And then you need to also consider the need for palliative or hospice care, as we have mentioned earlier, as to what would benefit the patient. So focusing on you as a doctor in the future, one of the sensitive issues about death and dying is this disclosure about being able to tell a patient that that they are suffering from terminal illness. Okay? You need to consider what the patient's need would be at that point of disclosure, because there is an intellectual and emotional approach. Remember that it is the patient's right to know, but also remember that it's also the patient's right not to know. For a long time, ago, doctors thought that we didn't have to tell a patient that he or she was dying, or that he or she had a terminal illness. So they just circled around it. Okay. And then there was a time that the the practice was to tell the patient everything. Okay. And then of course oftentimes that didn't work. But that's why it needs to have a careful balance, because again, as I mentioned, it is the patient's right to know, but it is also patient's right not to know. How will you know? It depends on how the patient feels at that point. You can always ask the patient. You can always start with saying, I have some bad news. I have the results of your tests. Would you like to know them? Okay. They usually sometimes they may say no, I don't want to know them, or they probably would ask, would it be good news or bad news? Now, what do we mean by intellectual versus emotional approach? Um, Doctors generally use the intellectual approach. Say, oh, you have cervical cancer, and these are the survival rates. These are the number of paid. These are the kinds of treatment. These are radiation therapy, surgery. Okay, so they just go on through a litany of factual information. Okay, which oftentimes the patient really doesn't hear, because oftentimes what generally would happen is that when you say that you have cervical cancer, that's when it all stops for them. Okay. And anything you say afterwards is totally lost, because when they hear cancer, that's it. That's it for a lot of them. But how would you do the emotional approach? That is, try to assess first how the patient is feeling at that point in time. Basta po kayo, ano po pakiramdam niyo ngayon? Meron po ba kayong inaalala? Meron po bang sa isip niyo may mga pumapagapag sa inyo? Tungkol po dito sa nararamdaman ninyo, sa magiging pag-uusap natin tungkol sa resulta ng mga eksaminasyon. It's often helpful if the patient can have a loved one. I remember a very good friend of mine who was living in New York at the time and was eventually diagnosed with lung cancer. Fortunately, I was there visiting my parents when he had his labs and things, and he asked me to accompany him when we went to this doctor at the Sloan Kettering Memorial. So I was there, I was holding his hand because I believe it was going to be a so that if you know that you are going to share some very drastic or terrible news with the patient, one of the strategies you can do is to have a loved one there, okay, to help them out, to provide moral support. And that can bolster the emotional. We need to also explore our own attitudes towards death, dying, pain, and disability. A lot of doctors cover up their anxieties about dealing with a dying patient by trying to recite that litany of factual information that I was saying. Oftentimes, there are doctors who even delegate it to someone else. I remember when I was in residency training, one of my senior consultants at the time received a referral, and the referral was very specific. Okay, refer to psychiatrist to tell the patient that the patient has cancer. Okay, and my consultant, I mean, he accepted the referral, but then he managed to work that through with the attending physician to convince him that it is actually the responsibility of the attending physician. So the referral, and anyway, you'll learn more about this when you go into consultation days. But what is important is if you're going to go into a field of medicine that's going to deal with a lot of terminally ill patients, a lot of patients who will be suffering from pain and disability, then you need to be able to practice how to approach them. You need to clarify your attitudes, your own inner anxieties about all this. Okay? And that's why you need to develop the skills of compassion and empathy, because those are two skills that would be very helpful in the long run as far as your career as a physician is concerned. So let me backtrack and talk again about the doctor's mom. So I've mentioned earlier that Ling Ophelia was diagnosed with major depression, and I started her on an optimal antidepressant therapy plus a hypnotic to help her sleep at night. She was also started an interpersonal psychotherapy to resolve her feelings of guilt and self-blame and to help her deal with the resentment and lack of support that her husband showed after she was diagnosed with cancer. So gradually over a period of 2 months, she started to improve and was able to maintain good improvement in the coming months. She was able to maintain good treatment for more than a year, was able to go back to her previous level of function. So at least in this case, it turned out really well because we needed to discuss a lot of her anxieties and fears. And it was truly unfortunate that at the time she was also still suffering from grief as a result of the death of her mom. And then a month later, she was diagnosed with cancer. And so therefore, this was a double whammy. That's why we would be able to think that, yes, we could understand why she went into depression. And of course, our role then was to help her understand all those things, all those issues, and be able to help her deal with all of them. So in conclusion, just like to state that death and dying are very complex concepts that one lecture is really not sufficient to be able to discuss all the nitty-gritties about these topics. And that it is clinically useful to understand the stages of the emotional responses of a terminally ill patient, because you will be encountering them in the future when you do your clinical practice. And that's why you need to be aware of at which stage the patient is in, so that you'll be able to tailor fit your response to your actions to the specific stage that the patient is in. And that's why it's very important for a physician to know the appropriate ways to assist the patient in this phase of life. To end, I'd like to share with you some that this was written by a nurse, Bronnie Ware. Okay, she wrote a book in which she talked about the top 5 regrets of the dying. The first one is I wish I'd had the courage to live a life true to myself, not the life others expected of me. I wish I didn't work so hard. I wish I'd had the courage to express my feelings. I wish I'd stayed in touch with my friends. And finally, I wish that I had let myself be happy. And with that, I end my lecture and hoping that be able to find some of the things that we've talked about useful as far as your future practice of physician. All the best to everyone.